Okay, we're going to do a few minutes here on Mal de Embarquement syndrome. And it's something that we've seen here semi-regularly. This is Dr. Randall Gates.
He is board-certified chiropractic neurologist as well as being a chiropractor.
And he works extensively with the types of conditions that fall in the same category as Mal de Embarquement syndrome, dizziness, vertigo, balance, some of the misdiagnoses or collateral diagnoses to Mal de Embarquement syndrome. I'm Dr. Martin Rutherford. I am a certified functional medicine practitioner. I'm also a chiropractor, 36 years, and have spent a lot of time dealing with, actually, even as a chiropractor, I've had the opportunity prior to getting into functional medicine to work with certain dizziness and vertiginous cases. But this is a whole different animal. And so based on melding our two disciplines of dealing with the brain and the nervous system, and then functionally dealing with the rest of the mechanisms of the body, liver problems, blood sugar problems, autoimmune problems, thyroid problems, things of that nature. By melding those two, we seem to have come up with some pretty consistently successful treatments for a variety of things that have been said can't be treated. So we're sharing what we know with you. We're sharing what we find. Dr. Gates is the lead doctor on all brain work and brain-related, although there's not an autoimmune component to this, right?
I haven't seen that.
Okay. So all brain-related, strictly brain-related types of problems in here. So he's going to discuss Mal de Embarquement syndrome with you. We see it. We see it. It's frequently misdiagnosed. And Dr. Gates can probably share the reason for that with you. But why don't you go ahead and share with these folks what they're probably interested in hearing.
So if you've been diagnosed with Mal de Embarquement syndrome, likely you've been out on a cruise, you've been on a boat, you took a tour to Antarctica, something of that nature, and you came off the vessel, and technically it has to be upwards of 7 months. But basically, if it continues to where you feel like you're still on the boat, you feel like you're rocking, you feel like you're swaying, you feel like you're bobbing up and down when you're standing or laying down, that's significant. And you can go see your ear, nose, and throat specialist. You can go see a neurologist. Lots of times, you can be diagnosed with Mal de Embarquement syndrome. We've made the initial diagnosis on a few occasions. And the history is very, very important, obviously, to Mal de Embarquement syndrome patient relative to the dizziness and vertigo world. You basically have to ask when it started, and the history pretty much tells the story. Another aspect of Mal de Embarquement syndrome patients is that lots of times they feel better with motion. So they'll say, man, when I drive my car, I just feel fantastic. But then I stop the car, and then that's when all my symptoms come back. It can be associated with anxiety because these sensations of motion go into a part of our brain that deals with anxiety, in essence. Now, relative to Mal de Embarquement syndrome as to why it happens, in the literature, they'll commonly say, well, we think that it's due to poor integration of sensory signals from the vestibular apparatus, which really means that the cerebellum doesn't filter those signals well. There's something termed a perseveration.
I don't think they know what a cerebellum is.
Cerebellum is a balance center in your brain. I'm going to go into it. But so a perseveration is where you maybe think about something
over and over and over.
You know, that song keeps going through your head. That's that's kind of basically a sensory perseveration. The same thing can happen relative to inner ear function. So you're out on the boat, you're rocking up and down for a week, then you come off the boat, and you still feel like you're rocking up and down. And that 7 days where you're out at sea created these signals in your brain that are now continually going and not being shut off. And in a normally functioning cerebellum, which is the balance center, which not only deals with balance, but it coordinates eye movements, it coordinates limb movements, it also prevents us from having things like dizziness and vertigo because it dampens the inner ear signals. If it's not doing so well and somebody goes out to sea for a week and then they come back, it may not be able to shut off all those inner ear signals. And as a result, an individual can develop this sensation as though they're moving all the time.
Right.
And so that is Mal de Embarquement syndrome in a nutshell. The current treatments for Mal de Embarquement syndrome are not widely recognized or accepted, but the ones being proposed deal with basically trying to reintegrate how the eyes interact with the inner ear. Mm-hmm. It's called the vestibulo-ocular reflex, just fancy word for a reflex that happens to try and basically retrain the cerebellum.
With exercises.
With exercises. Now, we do that as well, and we have a very particular way we do it, to where we try to not overstimulate the cerebellum. Usually if somebody has Mal de Embarquement syndrome, their cerebellum was not able to filter those inner ear signals. The cerebellum's weak to a certain degree, you can just say it that way for all intents and purposes. And so you can go back in and try and stimulate that cerebellum, but we have found it incredibly important to work within the ability of that cerebellum to produce its output, or we term it metabolic capacity. Use the analogy, if you haven't worked out in 2 years, don't put 400 pounds on the bench press and try and do it, because you're probably going to tear a muscle. Same concept applies to neuromodulation or neuroplasticity-based brain exercises, where we try and stimulate that cerebellum back to life.
And when patients come in here, and I know you're being kind when you said we've made a few of the primary diagnoses, but frankly, pretty much everybody's coming here that I've interviewed with Mal de Embarquement syndrome was told they had something else. And a lot of times it was as simple as Bppv. And you might want to explain that, because it's pretty common why people just defer to that, and maybe what Bppv is and why they defer to that. Or
okay, so in the vertigo world, if you see a neurologist, if you see your nose and throat specialist, first of all, they're trying to make sure you don't have a tumor,
right,
or you haven't had a stroke, because those are the big things that can cause someone to have vertigo, or these sensations of motion. They also want to make sure you're not having a heart attack. They want to make sure your carotid arteries are not plaqued up. These are all life-threatening things that can result in vertigo. If it's not one of those things, then lots of times patients will feel discarded. They'll say, my doctor said I don't have that, so, or you probably have Bppv, because your doctor has other things to do, and they're moving on to what they feel are patients with more significant problems. That's the fact of the matter.
Right.
If you have had that experience. And so we get a lot of patients who come to us who have been given maybe broad diagnoses like Bppv, which is where you can get little rocks in your ear that dislodge, you lay down, you get vertigo, but a lot of people are categorized under having Bppv, because in order to figure out the cause of dizziness, lots of times it takes an hour with a person. It takes 30 to 45 minutes of history to really garner all the details to really delineate what is actually going on with the inner ear and the brain, frankly, to see if they have a brain-based condition that may be causing it.
Yeah, we went a little bit longer, but I think it's important, because I did a video on vertigo and dizziness like years ago, and in there just cataloged Mal de Embarquement syndrome, but also visual vertigo, exocentric vertigo, egocentric vertigo. There's just so many different types of aspects that can go on, and yet a lot of people, once you don't, like Dr. Gates said, once you don't have a tumor, once they know there's not a cancer in there, there's not something like that, it's kind of like, here, take the meclizine, go try and do an Epley's maneuver if any of you had been told or had it done to you. I'm not going to say how frequently it's done incorrectly, but pretty frequently. Where they lay you on your back, they bring you down, and then they put you to one side, and then they turn you to the other side, and then they tell you how to do it, all that type of stuff. Sometimes they don't tell you how to do it right, but if they do tell you how to do it right, and it's done right, and you have done it more than 3 times, you probably don't have Epley's, or you probably don't have the Bppv. But the bottom line is that there are a lot of different factors that create different types of vertiginous, dizziness type of symptoms. And the Mal de Embarquement syndrome is unique unto itself, and that's why Dr. Gates indicates that it really takes a bit of clinical history taking, as well as a very specific and very comprehensive neurological exam to determine that that's the actual clinical entity that you have. Once that's known, then there are a lot of natural treatments that go beyond even what Dr. Gates just got done talking about, that can be very successful in a case like that.
Yeah, I think that pretty well summarizes it. Yeah. If you have more questions, we've done hour-long broadcasts on vertigo and dizziness, as Dr. Rutherford said. We just did one on vestibular neuritis and Meniere's disease. And even if you have Mal de Embarquement syndrome, it's not a bad idea to watch that, because we talk about the cerebellum at length and some of the factors. Even though I haven't seen any autoimmune studies relative to Mal de Embarquement syndrome, I wouldn't be entirely surprised.
I was thinking in terms of maybe an immune attack on the cerebellum.
Yeah, I would be entirely surprised if that is happening in Mal de Embarquement syndrome patients. And we've discussed in other videos where, you know, we've seen clinical findings for 3 years before a research article comes out basically substantiating what we've been seeing for a long period of time. So anyways, that's the data on the subject. And we appreciate you watching. If you have any other questions, go to powerhealthtalk.com or like our Facebook.
Thank
Thank you for watching.